Welcome to Fetal Medicine Forum podcast, where we dive deep into maternal and fetal health topics shaping modern obstetrics. Both my colleague and myself will dive into this fascinating subject.
Thank you. Always a pleasure. Today's topic is one close to our daily practice, the management of twin pregnancies. These are fascinating yet complex, with unique risks and surveillance strategies.
Exactly. Twins bring joy, but also a need for vigilant, evidence-based management. We'll explore everything from definitions and diagnosis to complications and timing of delivery. Let's begin with the basics: chorionicity and amnionicity. Chorionicity refers to how many outer membranes, or placentae, the twins share. Amnionicity refers to how many amniotic sacs they have.
Right, so we can have dichorionic diamniotic DCDA twins, each baby with its own placenta and sac. Monochorionic diamniotic MCDA, twins sharing a placenta but separate sacs, and the rare monoamniotic twins sharing both placenta and amniotic sac. And this distinction is crucial because monochorionic twins carry higher risks mainly due to shared placental vascular connections that can lead to complications like twin-to-twin transfusion syndrome, TTTS, twin anemia polycythemia sequence, TAPS, or selective fetal growth restriction, sFGR.
Good point. The global twin birth rate has increased significantly now at about 32 per 1,000 total births, largely due to advanced maternal age and assisted reproductive technologies.
With that increase comes risk. Perinatal mortality in twins is roughly threefold higher than in singleton pregnancies, mainly because of prematurity and complications of monochorionicity.
And let's not forget maternal risks: higher rates of hypertension, abruption, anemia, and urinary tract infections. Moving into imaging, the first trimester ultrasound is absolutely essential. It helps determine viability, gestational age, and most importantly, chorionicity and amnionicity.
Exactly. Ideally between 11 and 13 plus 6 weeks. The lambda sign or twin peak sign indicates dichorionicity, while a thin membrane or T sign points to monochorionicity.
And if chorionicity is uncertain, it's safest to manage as monochorionic until proven otherwise. We also evaluate the crown rump length, CRL, using the larger twin to estimate gestational age and note any early CRL discordance, since a difference over 10% could predict later TTTS, or discordant growth.
Screening for aneuploidy is also important. In twins, nuchal translucency, NT, combined with maternal age, can reach about 75% sensitivity. Risk calculation differs. Monochorionic twins share a singleton equivalent risk, while dichorionic twins have roughly double the age-related risk.
Next comes the second trimester anatomy scan, ideally at 18-22 weeks. Congenital anomalies are 1.2 to 2 times more common in twins, so this scan must be detailed and methodical.
And when severe malformations are detected, fetal reduction may be discussed. In dichorionic twins, reduction is performed by transabdominal potassium chloride injection. In monochorionic twins, it's contraindicated due to shared vascular connections instead. We use laser coagulation, bipolar cord coagulation, or radiofrequency ablation to stop blood flow selectively.
Monitoring growth is also key. We use singleton growth curves for now, and we define selective FGR differently for dichorionic and monochorionic twins. For instance, in monochorionic twins, having 3 out of 4 criteria, low estimated fetal weight or abdominal circumference is greater than or equal to 25% discordance, or elevated umbilical arterial pulsatility index confirms sFGR.
For dichorionic twins, at least 2 out of 3 parameters are needed. It's all about differentiating true pathology from normal twin variation.
Preterm birth is a major challenge affecting nearly 60% of twin pregnancies. Transvaginal cervical length measurement remains the best predictor.
Exactly. A short cervix is a red flag, but interventions like routine progesterone, bed rest, or prophylactic cerclage haven't shown consistent benefit. Corticosteroids shouldn't be used routinely either, only when preterm delivery is imminent.
Now, let's discuss those monochorionic complications, starting with twin-to-twin transfusion syndrome, or TTTS.
TTTS affects about 10 to 15% of monochorionic pregnancies. It's diagnosed by discordant amniotic fluid volumes, oligohydramnios in the donor twin and polyhydramnios in the recipient. Dopplers also help. The donor may have absent diastolic flow, while the recipient can show cardiac overload or tricuspid regurgitation.
Without treatment, mortality can reach up to 90%, but with fetoscopic laser ablation, survival improves dramatically to about 66–77%. These pregnancies are usually delivered around 34–37 weeks if stable after therapy.
Then there's TAPS, twin anemia polycythemia sequence, characterized by hemoglobin differences without amniotic fluid imbalance. We screen using middle cerebral artery peak systolic velocity Dopplers every 2 weeks, over 1.5 mom in the donor, under 1 inch is the recipient. Management can include laser coagulation or intrauterine transfusion.
And of course, selective fetal growth restriction, sFGR, which occurs in about 12–25% of monochorionic twins. It's classified into 3 UA Doppler types. Type 1, positive diastolic flow, good prognosis. Type 2, persistent, absent or reverse flow, high mortality. Type 3, intermittent absent divided by reverse flow, unpredictable and dangerous.
Treatment is tailored from conservative monitoring to fetoscopic laser or selective feticide for severe cases.
Let's not forget twin reversed arterial perfusion, TRAP, sequence rare but serious. The pump twin supplies a cardiac twin, risking heart failure. Intervention is needed if the cardiac divided by pump ratio is at least 1, or Dopplers show cardiac strain options include radiofrequency, ablation, or cord occlusion.
Monoamniotic twins are particularly high risk due to cord entanglement. These pregnancies need fortnightly ultrasounds, and caesarean delivery around 33 weeks is recommended.
If one twin dies, management depends on chorionicity. In dichorionic twins, we monitor the survivor weekly, no need for preterm delivery unless complications arise.
In monochorionic twins, however, the surviving twin faces serious risks death in 15% and neurological injury in nearly 30%. Weekly Dopplers, especially middle cerebral artery peak systolic velocity, are vital to detect anemia, and we usually deliver around 34–36 weeks after giving corticosteroids.
So when should we deliver twins? For uncomplicated monochorionic twins, elective birth from 36 weeks is generally safe, while dichorionic twins can go up to 37 weeks. Beyond 38 weeks, the risk of stillbirth increases.
Preterm birth remains common, but the goal is balancing neonatal maturity with avoiding intrauterine risk. And multidisciplinary care involving obstetricians, neonatologists, and fetal medicine teams is the cornerstone of successful outcomes.
That was an incredible overview, from the basics of chorionicity to advanced interventions like fetoscopic laser therapy.
Thank you. Twin pregnancies are truly a world of their own, challenging, unpredictable, but deeply rewarding when managed well.
And for our listeners, whether you're a clinician, student, or just curious, remember that early diagnosis, vigilant monitoring, and multidisciplinary teamwork are key. Join us next time as we discuss fetal interventions and intrauterine therapy.
Until then, stay curious, stay compassionate, keep learning, and don't forget to scan the QR codes on the screen or click on the links below for more material.